My gastroenterologist did all the colonoscopies, the gastroscopies. He actually sent me for an MRI, and in the end told me that it was in my head.
From what I recall, I don't think any of my doctors has talked to me about diet and stuff. It's all from what I read.
But the bloating has been quite nasty. I can go up and down 2 or 3 dress sizes. It's ridiculous.
I couldn't do my pants up because of the bloating, and I was just in pain.
But I've always had digestive issues, always.
Beetroot, cauliflower and broccoli are my trigger foods.
Cauliflower, corn.
Never have any fizzy drinks. I'm careful with garlic and different spices.
Onions, apples and pears.
Yeah, for me it's more sugar, red meat and dairy.
Oh, lots of sugar and alcohol. I'll just go up like a balloon.
Well, I became vegetarian.
So I was on the FODMAP diet for a while.
I've also been vegan since the start of this year.
I've gone completely gluten-free, which I think has made the biggest difference.
Gluten definitely does not agree with me. I can have a little bit of dairy, but there's definitely like a limit. After the breath test came back negative for celiac disease, it just didn't occur to him that it could be anything else.
I went to visit a holistic dietitian and I told her I had endometriosis, and she said eating a gluten-free diet, a whole food diet, would be of great benefit. And it was.
And we did go gluten-free for a while on the recommendations from the gastroenterologist, but it wasn't making a difference.
So they did diagnose me with IBS, very lactose intolerant.
Every doctor that I've seen about my endometriosis has commented that it's probably just irritable bowel syndrome.
And I never knew the link between IBS and endo or gut and endo. I always just thought that was just me.
And then I started developing pains with my bowel and my bladder, and it would hurt to go to the toilet.
Do you know that there are specific ways you should sit on a toilet to do number 2s? Had no idea.
I'm going to try something a little bit different. It may or may not work, but if I could get you to take out your smartphones and go to menti.com if you're connected to the internet, and then enter the code that you see on the screen there. But I'm actually quite interested to get a bit of a feel of what's happening in the room at the moment. So if anyone can just answer that question for me to the best of your ability. All right, I suspect we could keep going up with that one. I am going to move on to the next question just in the interest of time. Of those people that said yes, how many do you think it's related to the endo? I'm sensing a common theme here. Who here thinks diet is important in managing their symptoms? It's a little bit what I suspected. We'll move on to the lecture now. So I'm a gastroenterologist. I'm not a gynaecologist. I'm not an expert in endometriosis. But I do head the functional gut clinic at the Alfred, and we do see quite a few patients who've got symptoms and do also have endometriosis. So my disclosures, I do speak for BAM on some advisory boards, and obviously I work at Monash and Alfred Health, which is the home of the low FODMAP diet. It's very likely to have a potential bias in that area. I use it every day. So this is guts. Guts is not the most sophisticated individual, shall we say, and generally any abnormal structure or function of the gut often manifests in kind of one of 3 ways, really. Either diarrhoea or constipation, or abdominal pain and bloating are the main things that we see. So when should you think of endometriosis in patients who have got gastrointestinal symptoms? As you know, there's often a long time lag before there's proper diagnosis, and that's because actually gut symptoms are incredibly common, and 25% of the population have got functional GI symptoms, and may meet the criteria for irritable bowel syndrome. And this is actually something that we looked at with my PhD student, who looked at patients with irritable bowel syndrome with and without endometriosis. There are a couple of issues with the study, in that those that were not known, we didn't have laparoscopes or imaging in all patients to exclude a definite diagnosis. But when we looked at those with endometriosis, they were younger age in average, which is not dramatically surprising. There's a big risk increase if there was a family history of endometriosis, again, not dramatically surprising. if they had pain, and particularly pain with sex or referred to the back and pelvis, it increased the likelihood that they may have had endometriosis. And of course that their periods were affecting their symptoms as well. And actually there's not that much literature out there looking at this problem. So why do you get gut symptoms with endo? And actually there's lots of reasons why you can, and that complicates things a little bit. So you can have direct involvement of the gut, obviously, and you may have complications from the endometriosis or the surgery, development of adhesions, for instance. Certain medications to treat endometriosis are going to upset the gut and affect the gut, sometimes severely. And of course there's also the common development or association with functional GI disorders. So few things that I want to go through because I don't want to move outside my area of expertise, and what I won't be talking about is your deep infiltrating endometriosis or your intestinal endometriosis. I'm not going to talk about surgical treatments for endometriosis. I'm not going to talk about targeted medical treatments. You've had vastly more qualified people than me talk about these things, and I'm really a dunce in this area. The only thing I share in common is the love of bow ties. But what I will be talking about instead is functional GI symptoms in endometriosis, which are incredibly common, the potential mechanisms for these symptoms in endometriosis, and also some potential non-gynecological treatment options that we can look in patients with gut symptoms and endometriosis. So the first thing to say, as you saw from my little test before, gut symptoms are incredibly common, and there has been some studies looking at that. Up to 90% of patients have got significant gut symptoms. So this is an incredibly common thing that we're dealing with, and to be honest with you, we often don't deal with it very well. So patients with endo do have more frequent and more severe symptoms of pain, bloating, constipation, problems with having to go to the toilet, either rushing or having difficulties emptying their bowel, which is called incomplete evacuation, hence the important way to sit on the toilet normally. The onset is often gradual in the majority of people, and often the symptoms are intermittent and can be cyclic, which is not surprising, and in some, unfortunately, they can be quite progressive. Bloating is by far the most common symptom and is generally described as the most severe symptom reported as well. But of course, as we've talked about already, pain is also a major issue, and the big concern for me is almost 20% of patients have been prescribed opiates for their pain, which I hate opiates because they always cause gut problems as well. Sometimes, yeah, they are necessary, there is a time and a place for it, but I actually spend half my life getting patients off opiates because in the long run it tends to make the problem worse rather than better. So I guess one of the questions is, does the location of endo particularly matter? And actually the short answer is probably not. There has been some studies that have looked at kind of deep invasive endometriosis before, in comparison to more superficial or mild moderate, and actually the symptoms were not significantly different between the groups. Those with, say, rectal involvement and deep endometriosis were a little bit more likely to have rectal stenosis and constipation, but actually the area and the involvement of the endo is not a big feature. And what about surgery in endo? Is that helpful? And yeah, look, in pain, definitely there's evidence that that's going to be helpful. But actually the evidence is not that great in patients' GI symptoms, particularly constipation and defecation problems. And there is some evidence that sometimes with surgery it makes things worse, not better. This was quite interesting, and I think summed it up quite nicely from the paper that this study was from. And really the summary was digestive symptoms in endometriosis. They're really a result of cyclic inflammatory phenomenon, and that leads to irritation of the digestive tract, and it's not necessarily the result of actual involvement of the gut by the disease. And that's really important because I want to introduce you to the concept of the sensitive gut, or actually the irritable gut is the other word. So as I said, 90% of patients will have GI symptoms, but only 7% of them have got bowel lesions that are contributing to those symptoms. And it is a little bit the case of the princess and the pea. So patients have been sensitised, as we heard before from Dr. Craigie, from chronic inflammation, from chronic pain, and they are really able to pick up on normal gut stimuli that actually can present as pain, can present as diarrhoea, and can present as constipation. So this has been looked at in a slightly more scientific way, and we term it visceral hypersensitivity. So in this study from Manchester in the UK, what they took was a whole heap of patients that had mild to moderate endometriosis at laparoscopy, those with moderate severe endometriosis at laparoscopy, those with irritable bowel syndrome, and those that were having a laparoscope for reasons other than endometriosis. And what they did, it's not the nicest experiment in the world, but they put into the rectum a catheter with a little balloon on the end of it, and they inflated that catheter, similar to the distension you'd get when stool goes into the rectum. And what they found is that healthy individuals, the onset of pain and sensory thresholds were about 40 millimetres of mercury pressure. So if we kind of extrapolate that out across the group, you can quite clearly see that those with irritable bowel syndrome, which we would expect, they're more sensitive, they're more irritable, are getting that sensation of pain at a much, much lower pressure than those healthy individuals. And actually that plays out for those with moderate severe endometriosis and also the minimal and mild endometriosis as well. So it's not really something that is impacted by severity of the disease, it's kind of presence of the disease. And the way I kind of like to look at that, removing the sciencey side of it, is basically the threat response picture that we're looking at here. And I think everyone can kind of understand what I'm talking about. If you're primed for pain, you're primed to feel awful, you're going to have a much greater response to it as well. And this horrible cycle continues to go on and really amplifies the problem. So this is quite important to know though, because it does give you a degree of control over your symptoms, of understanding the mechanism, particularly with the GI. Understanding that hypersensitivity and overreactivity of the body can help produce the panic, or catastrophizing is the term that we often use, that occurs in the setting of pain, and that actually makes the problems worse. The pain is real, not disputing that in any way, shape or form, but as we heard in the last lecture, we do have the ability to use techniques to try and minimise that amplifying response. So when you get pain, the normal response is, oh my gosh, tissue threat, danger, run away. That's entirely normal. And what we're kind of often asking our patients with chronic problems is to try and ignore all our natural urges. But it does help to understand the physiology behind this, so that when you do have the pain, you can actually cognitively understand that, oh, actually it's an overreaction and I don't need to run away and panic as much. And that can be quite powerful. The other advantage of understanding this is it does give us some targets for treatment as well. So this is where I get onto diet and endometriosis, and this is a really tricky area because we actually don't have much data. There is a profusion of diets for health, wealth, well-being out there in the community, from the Mediterranean diet for the Paleolithic, specific carbohydrate, anti-inflammatory, 5-2, raw food, vegan, vegetarian, pescatarian, low FODMAP, gluten-free, low chemical. It just continues to go on and on and on. Most of these have very little evidence for them, and it is really difficult to know where they fit in the treatment options for patients with chronic gut disorders. So certainly when we look at diet in endometriosis, we focus it in a little bit. Certainly there's some recommendations that we should be avoiding high fats or certain high fats. There's a lot of stuff on the internet about the anti-inflammatory diet. And if actually anyone can tell me exactly what that involves, I'll be really happy, because every website I looked at was different. Gluten-free diet, again, very popular, and the low FODMAP diet as well, certainly in the treatment of irritable bowel syndrome, has really taken off across the world and has a host of data behind it in that group of patients. And then, of course, there's the kitchen sink diet, where you go and you see all these different people. You take out meat. Oh, actually, no, I'll take out dairy. No, you definitely should not have carbohydrates. Or, no, you should be high fat. And I see an enormous amount of patients that are eating steamed chicken and rice, and that's it. And I also see a large number of patients that have got micronutrient deficiencies, have got significant weight loss, and are getting complications because of severe over-restriction. I know I work in the home of the low FODMAP diet, and you would think I'd be putting every second patient on the low FODMAP diet, and I do use it a lot. But actually, I spend more of my time getting patients off diets that are damaging for them and not helping them. If a diet's not working, don't add another diet to it. Stop it. It's not working. You need to have a broad amount of food so you can get your nutrients. So with this, I guess it's time to look at the data. Now, really, the question with data and what's out there is there any, or what I like to call the Zoolander effect? So let's look at the science here, and to be honest, it's not great. So what about fat in the diet? Now here there is a little bit of evidence. It's particularly epidemiological, but we know there is an increased risk of endometriosis, certainly when they've looked at large studies of women like the Nurses' Health Study that have got a high intake of trans fat. And correspondingly, there's a decreased risk of endometriosis in women that are in the highest quintile of intake of omega-3. So that's really encouraging. It can help stratify risk. But what do you do when you've already got endometriosis? Well, there is some data that a high-fat diet may promote the development of endometriosis lesions, and there is a little bit of evidence that administration of anti-inflammatory omega-3 fatty acids, such as fish oil, reduces the development of endometriosis nodules. And that's fantastic news if you look like this. We don't have great data in humans, and there's one study that has looked at this a little bit. This was a study in patients that had undergone pelvic surgery for severe endometriosis, and then after their surgery, they randomised them to either medical therapy or dietary therapy or placebo. And the dietary therapy was essentially vitamin and mineral supplementation, a probiotic, and the omega-3 and omega-6 fatty acids. The frustrating thing with this diet is although from baseline to the 12 months they all got better, which they'd had surgery, there actually was no difference between the three groups and placebo, which is a little bit disappointing. So what about those patients that have got significant symptoms but without marked endometriosis nodules? So the way I like to think of this, in this patient group, it really is that sensitisation that is the problem and that irritability. So how do we de-stress the bowel and what options do we have? So the things that tend to stress the gut, active inflammation, and now whether that is from a GI infection, whether that's from inflammatory bowel disease, or whether it's something like endometriosis, it's all going to impact. Certainly medications will stress the gut. Opiates will make a big impact on your gut, for instance. But also things like generalised stress, which activate your sympathetic nervous system and the fight or flight response, that runaway panic response, will stress the gut, and also bowel contents. So they will cause luminal distension and they will trigger symptoms. So I like to think of them as the 3 Fs, faeces, fluids and farts. And that's important. We can't do much about the active inflammation necessarily in endometriosis because we know even if the disease is relatively controlled, there's that sensitisation. Certainly we can look at medications, we can tweak them and change them. But what I really want to talk about is the next two, and particularly the last one, which is that luminal distension, because that's really where diet comes in. So there is a lot of interest in the gluten-free diet, and certainly the video at the start of my talk highlighted this. So it's definitely got the celebrity endorsement, which is fantastic because we all know that's essential to a good dietary treatment. It does actually appear to reduce symptoms. There's 2 studies looking at this from Italy, both from the same group. One's been published and it's very difficult to access. The second one's only in abstract form, which is always a little bit of a red alarm for me, as I always start to wonder why hasn't it been published fully. But that did show that 75% of patients did have improved pain with a gluten-free diet. They didn't really look at the other GI symptoms though. And they kind of postulated that maybe gluten induces an immune-mediated increase in pro-inflammatory cytokines, which may be possible. And a similar mechanism has been thought that it may cause symptoms in irritable bowel syndrome as well. But I think the question still hasn't been answered is whether the benefits are actually due to the removal of gluten. And this is where I get onto my pet topic, I guess, which is the low FODMAP diet. And this is a more broad diet. It does consider all of the indigestible and poorly absorbed short-chain carbohydrates, so fructose, lactose, fructans, of which gluten is one, and the galactolysaccharides and the polyols as well. And all of these, because they're poorly absorbed and have osmotic effects, all act to distend the intestine, either from gas or fluid, and that leads to symptoms. So that's kind of the concept in a nutshell. So any familiar foods that anyone can see on this? I certainly know from the talks at the start that a lot of those ones were listed, and that's something I see a lot with all my patients with irritable bowel syndrome as well. The low FODMAP diet looks at removing these foods and replacing it with whole foods that are less likely to ferment and are less likely to have the osmotic effects. So the way I like to think of it, and I thank one of my colleagues for this excellent slide, if you look at the small bowel and the large bowel's got lots of happy bacteria that live there normally. Food goes into the small bowel and travels all the way down into the large bowel. You've got your fructose, your polyols, your oligosaccharides, your lactose. These have an osmotic effect. They draw water into the bowel. That water can distend the bowel and cause stretch, which can cause pain, and that water can go into the colon, and that can make the stool more liquid and cause diarrhoea. Also, many of those foods are poorly absorbed in the small bowel, and they travel all the way through to the colon, where the happy, hungry bacteria eat them up, ferment them, and produce gas, which again distends the bowel and can cause pain. So this can result in increased water, increased gas in the bowel, that swells the bowel. In someone that's sensitised, that's going to cause pain, it's going to cause bloating, it may cause wind and diarrhoea and constipation. And this is backed up with some good science. This was from the group in Nottingham in the UK, who clearly had a much greater research budget than I do, because they looked at MRIs of patients with healthy bowels and also irritable bowel syndrome. And they fed them a whole heap of different foods and then put them in the MRI scanner for a long amount of time and looked at what happened to the bowel. So if you look at these scans, white is water and black is gas, and you've got glucose, which is the equivalent of baseline, and you can see there's not that much water around, whereas if you've got fructose, you've got quite a significant increase in the small gut water. Correspondingly, if you give someone an inulin, which bacteria loves and can ferment, you can see at baseline, or about 300 minutes later, there's quite a significant increase in the gut, in the gas production and distension. The other really important thing that I want to highlight here is this phenomenon happens in healthy individuals and in patients with irritable bowels. Guess which group gets symptoms? So we looked at this very briefly in patients with endometriosis, and this was led by my PhD student down in Melbourne, Judy Moore, who's a nurse who ran a very successful nurse-led IBS clinic in New Zealand before coming across to do her doctorate. And she used to be sent a lot of patients from gynecologists for help with management of symptoms, and she thought, oh, well, maybe we'll give the low FODMAP diet a go. And there's about 160 patients all up. I think about 60 of them had endometriosis and about 100 didn't. And she was really surprised to find that when administering the low FODMAP diet, actually those with concurrent endometriosis had an even greater response than those with the IBS alone. And that may well be because in endometriosis it is that hypersensitivity hypothesis. This is really all the data we have at the moment, so it's not great, and I think there's a lot of area for improvement in our science in this area. So in terms of how you can access the low FODMAP diet, Monash University does have an app that can give you a little bit of information on it, and that's a traffic light system with low, medium or high FODMAPs that can give you a bit more control. But there is a bit of a word of caution that I really want to drive home today. Now, diet is medicine, and I think everyone here would agree with that, and certainly the little straw poll we had at the start shows people understand it's important therapy. But it really does ask the question, do we treat it the same as other medicines? So in Australia, if you want to get a drug approved, a new drug on the market, you have a good idea. Yep, this is great, this is going to work for this condition, and then you have to test it. So you have to run some clinical trials. So first you have to do a phase 1 clinical trial, and then you test it on a few people, make sure it's safe and it's not going to cause any major problems. So that's one. Then you move on to the next clinical trial. So you treat a bigger group of patients, and you actually, in that case, you're looking to see if it works. Does it make a difference to their symptoms? And at the same time you look, is it safe? Then you move on to a phase 3 clinical trial, and in that you have to compare your drug to an existing standard treatment and show that it's better, and also recheck that it's safe. I'm going back to that safe every time. And then you've got your stage 4, is that after you found it works and it's better than the standard treatment, you then have to monitor it and follow it up to confirm that it is definitely safe. And if it's not, it's withdrawn from the market. Then you have to go to the TGA, and we all heard the glory of bureaucracy in our last lectures. That can take quite a long time. Then goes to an expert advisory review. It's then approved, and then there's ongoing monitoring and follow-up. How do you get a diet approved? You have a really good idea. You put it on a website. And maybe get some really, really ridiculously good-looking people involved. Now, there's also some concern with that, as we've had a number of cases it's seen, and tragic as they are, it's a bit sobering to realise that you can easily fall at risk to people who, possibly for the best of intentions, are not doing what's in your best interest and may well be harmful due to the lack of understanding. So, diet is medicine. We know that. We should treat it as such. And I think this is the important take-home message from my talk. You need to be aware of the risks. Inadequate nutrition is common Over-restriction, the risk of anorexia or orthorexia is a big problem. I see it a lot. Some diets worsen symptoms. I see a lot of patients that are on a really high-protein diet, for instance, and have horrible constipation because they've just slowed their entire gut motility down. And as I said, I spend a lot of time taking people off diets and broadening them up. There's also a new emerging area that we don't really understand well, but it's clearly critically important, and there's an enormous amount of research in this. And that's the changes in gut bacteria and how that impacts on symptoms as well. So there's a big watch this space with this. So from my point of view, and I guess the summary here is if you do want to explore diet as a treatment, please do go and see someone who is qualified to assess both the benefits and particularly the risks of diet in you. Do approach it like you would starting a new drug. Research the risks, the benefits, the complications, because diet is medicine. And if it doesn't work, stop it. Stop accumulating diets. I regularly see patients who are vegetarian on a low FODMAP diet, add in a low chemical diet, and it's not good for you. If it doesn't work like a drug, you would stop it and move on to something else. And the other thing I would say is don't do it yourself off the internet. So the other thing that I would like to really highlight, and this quote's from me, is that I'm actually surprised and quite annoyed that there's such limited evidence examining the role of diet in endometriosis. This is not a very scientific comparison here, because I did it about 5 minutes ago when I was sitting in the last lecture, but if you put in diet and endometriosis into PubMed, which is where all the medical journals get published, etc., there's 98 papers. If you put diet and prostate cancer in, there's 1,868. So I think we've got some areas that we need to focus things on.